factors include decreased gastric acid secretion. Makes sense because the acid in our stomach helps kill the bacteria we get from our environment and protect us. And also small intestine dysmotility from abnormal muscle and nerve function. Normally we get a nice peristalsis after meals that our intestines move our food through, and when that's not working correctly, the food gets stagnant, and then this can also create an environment for bacteria to flourish. Some common symptoms include a lot of bloating, abdominal distension, a lot of abdominal pain or discomfort, and these symptoms are typically worse after meals. Typically the best time of day for these patients are right in the morning when they don't really have a lot of food in their stomach, and once they eat a meal, it feeds that bacteria. Also diarrhea or constipation, fatigue, and weakness. So a lot of research studies have actually recognized the symptom similarity between IBS or irritable bowel syndrome, and in some of the research studies, up to 84% of people with IBS had SIBO. So for diagnostic testing, typically we do a breath test, and this tests for hydrogen or methane gases, and these gases are released by the bacteria when they feed on the sugars that we eat in our diet. So typically you do a baseline collection after you wake up, you drink this sugar lactulose solution which will feed the bacteria, and you'll do samples of your breath at different time intervals. Conventional treatment, so SIBO typically still is not recognized that often by conventional doctors, but I have seen that some gastroenterologists have started testing for it, which is great. Typically, they choose an antibiotic called rifaximin, which has a really good specificity just for the GI tract. It's not well absorbed into the systemic system, and so it has good bactericidal activity. The next antibiotics that are typically used are neomycin and metronidazole. So our case history. This was a 39-year-old female who had daily abdominal bloating and pain for about 18 months, and she had these symptoms intermittently over the past 6 to 10 years. Severity was about a 7 out of 10 for the abdominal pain as well as the bloating, and she was really worse after meals. She would feel like she was 5 months pregnant, rumbling, gas in her bowels. And so this really limited her social life too. She was afraid to go out and eat at a restaurant, didn't know how she would react to eating certain meals. Some really interesting pertinent history is that she has this history of constipation for 15 years. So she would only have a bowel movement every day with 1,400 milligrams of magnesium and 4 grams of vitamin C. That's a fair amount. And so we think this may have played a role into creating environment for SIBO. Also, she was born with 4 ureters, so she would have frequent UTIs as an adolescent and had to take antibiotics daily for several years. And we know antibiotics can create a different environment for creating, different bacteria to grow that don't normally grow in the intestine. So here's her SIBO breath test. And you can see after about 40 minutes, the hydrogen gas increases significantly. So in her case, the hydrogen gas is what increased the most, and that is the more common one that will increase in SIBO. And so she's in the mild category, which we were surprised. We thought she'd be a little bit higher because of the severity of her symptoms, but nevertheless, she still tested positive. Treatment. So we started a low FODMAP diet, which stands for fermentable oligomonosaccharides and polyols. And this is just the types of sugars that feed those bacteria. So we want a diet that is low in these, we're not feeding them. And then we also started her on a couple botanical formulas. The first one, Candibactin BR, was a combination of herbs that were geared towards killing the bacteria, so reducing the load. And then the second herbal product was Candibactin AR, which these herbs also had antimicrobial activity, but they also are aromatic herbs that decrease gas, decrease the spasms in the intestine that create a lot of the pain. And then additionally, we started a homeopathic medicine called Colisynthis because she had abdominal pain that was really worse, better with pressure, better with warm applications. She had this rumbling sensation in her bowels. And this also was good for a history of using cathartics for constipation that really wasn't working. And we also started her on a probiotic, VSL3, because of her history of antibiotic use. So here's just a sample of what the low FODMAP diet would consist of. So these are the foods she can eat. So these ones don't really have the sugars that are going to feed the bacteria. And then here are the ones that are higher, and they're really going to exacerbate. How many people have had a lot of gas and bloating with beans? So people with SIBO really notice the change when they eat those types of foods. So here's just a graph of her abdominal pain through treatment. Shortly after she started treatment, I'll use this other laser pointer. Shortly after she started, she had a good improvement. She wasn't really experiencing many symptoms. She noticed when she veered off her diet, maybe beans snuck in that she wasn't supposed to eat. She did get an exacerbation. But something interesting happened around day 17. She had an exacerbation of her abdominal pain, but this was because she was having 12 bowel movements a day, and she had her history of constipation. So, we're like, is this a bacterial die-off reaction? She's eliminating all this bacteria that she's had. Maybe she was sensitive to the herbs. Maybe she was aggravating to the homeopathic. We don't really know. So nevertheless, she shifted. So that was good to see. So we stopped all the products she was on just to make sure nothing was aggravating. But she continued the low FODMAP diet for a period of time. And she really didn't have much pain after this episode resolved. And then again, she had beans and other food snuck in her diet, and she had a day that she noticed symptoms. The bloating also responded really well. Similarly, days she had foods that were off the diet that snuck in, she'd get symptoms. And this was through about day 41. Long term, she followed up on day 83. Her abdominal pain and bloating had kind of gradually returned, and she didn't have any change in the constipation. So what we concluded is we didn't think the SIBO was fully eradicated when we stopped those botanical herbs earlier on when she aggravated. So we started her back on that, but at a lower dose, just 1 cap twice a day of each of the herbal products. And we didn't restart her on the probiotics because there is controversial research on probiotic use with SIBO. Some of the research says people do really well with probiotics, and then there's also people with SIBO that they take probiotics and they do get an exacerbation because you're increasing that bacterial load. So I've seen both sides in the research. So 1 week after she started the botanical herbs again and continued the diet, her abdominal pain and bloating had resolved without exacerbation. And then continuing on, it's been about 10 months since she started treatment, and the abdominal pain and bloating is still resolved. She's still continuing the diet, but now we're focusing on that chronic constipation, which we think really contributed to her forming SIBO. And I've been told that she's starting to respond with homeopathic treatment. So this case supports a multifaceted approach to the treatment of SIBO, including diet, herbs, homeopathy, and so it just really shows how versatile our medicine is and how much we can do. That's it. Any questions?
Dr. Kwiatkowski mentioned that SIBO is not as widely recognized conventionally. The 2 centers that I'm familiar with, one is at SIBO centers, one is at National University of Naturopathic Medicine, but the other one is at Johns Hopkins. And Johns Hopkins actually published a study on 104 patients comparing the drug fixative and herbal treatments, and showed the conclusion is that the herbal treatment is as efficacious as the herbal. And our next presenter, our next resident, is Dr. Johanna Mauss. The use of multiple sampling and SAF-FIxative in the triple Faeces test for identifying and treating dysbiosis and pathogenic infections of the GI tract. Case study. Dr. Mauss, I remember when you were first coming here as, I think it was either as a prospective student or maybe you were talking to a prospective student. She was an EMT, and she kept seeing the same patient or patients returning to the emergency room because originally she had planned to go into allopathic medicine. And she went home and was really kind of discouraged. And it was her mother who introduced her to Dr. Robin Murphy, who was one of my teachers way back when. naturopathic physician, and it was her mother who kind of got her on the road to go to naturopathic medicine, all the way from Blacksburg, Virginia. So let's hear it for Dr.
Can you guys hear me okay? All right, so my case study has a big scary name. So what I'm really going to be talking about is GI parasitic infections and dysbiosis and the proper testing required to identify and properly treat them. All right, so gastrointestinal infections. Most acute GI infections resolve in a few days. Classic symptoms are fever, diarrhea with or without mucus or blood, nausea, and abdominal pain. I'm sure everyone in this room at some point in their life has gotten an acute GI infection. Maybe they didn't eat something that agreed with them, and they had a couple rough days, but then it resolved. Well, if those symptoms last longer than 2 weeks, stool testing is recommended. So let's talk about chronic parasitic infections. Parasitic infections that aren't treated long-term can increase gut permeability, create irritable bowel syndrome, cause malabsorption, gastritis, indigestion, skin disorders, joint pain, allergic reaction, damage to the gut lining, increased inflammation, and decreased immune system. As you can see, the last two, increased inflammation and decreased immune system, those could create a whole world of symptoms that aren't even on this list. So sometimes it's hard to identify exactly that an infection is in the gut because the symptoms can be so globally in the patient. So using sensitivity testing is the most effective way to determine what the infection is and to treat it. So what are the standards with that? So the standard of practice in medicine is a fresh stool sample that's collected on 3 separate days and then presented to the lab. But this is commonly not utilized. It's rarely used, actually. And here's the reason why. Very short periods of sample viability. In some cases, some of these parasites have to get to the lab within 30 minutes of that stool exiting the body for them to be accurate. Second is limited access to labs that process fresh samples. Most of the labs that process these are in big hospitals. So patients might even have access to them, or it's very difficult to get access to them if they're not in a hospital setting. The other is low patient compliance. Don't know how many of you guys want to take a fresh stool sample, run it to the hospital, and do that 3 days in a row in under 30 minutes. So there's been some advancements in the field with fixative products, testing that uses fixatives. So these tests can be done at home, and patients can bring them in so that you still get the effectiveness of a 3-day stool sample, but you can use them in an outpatient setting, like we do here at SCNM. Okay, so let's talk about my patient. My patient was a 50-year-old female that presented with the following symptoms for 3 years. She had a constant, vague, diffuse abdominal pain. She had constipation, gas, and bloating, and changing stool qualities. While most of the time she had really hard stools, she would suddenly get a well-formed bowel movement followed by diarrhea, and this would cycle. She had joint pain, which she described as constant, achy, dull pain in the hands, knees, and hips bilaterally. She also had morning stiffness that would resolve with movement in the morning. She reported hair loss in the form of excess shedding and thinning, brittle nails, and pruritus that was constant and isolated at her scalp. She reported intermittent tingling of her hands, weight gain of 25 pounds in 2 years with no major change in diet or exercise, fatigue and malaise, constant headaches, and palpitations that were unrelated to stress. Other important components of her case included this patient worked for an organization that required her to travel to Africa for long durations for the majority of her adult life. So she had a long history of exposure to parasitic and GI infections that were treated with various antibiotics and antifungals over the years, and to her knowledge had been completely resolved. 3 years prior to seeing us, she had an acute infection while traveling that involved difficulty breathing, hair loss, joint pain, extreme fatigue, pruritus, and blackening of her fingertips. She was treated, and though the acute episode and these symptoms for the most part resolved, she was never well since, and then she gradually got into the state that she was in when I went over in the last slide. All cardiac pathology, joint pathology such as rheumatoid arthritis, OA, and anemias were ruled out by a whole list of specialists that she had seen before us. She'd had a colonoscopy the year prior, which was completely normal, and physical exam was normal except for tenderness and guarding in the left lower quadrant of her abdomen, fogginess, which is a fancy word for saying like the feeling of swelling in her small bowel. So how did we work up this case? Guess what? Stool analysis. So we use Doctor's Data Comprehensive Parasitology ×3 stool test. This is a fixative-based test that we offer here at SCNM. This stool test offers a stool culture of beneficial, imbalanced, and pathogenic bacteria, as well as microscopic analysis and cryptosporum immunoassay. So it identifies a very large variety of pathologies that could be affecting the patient. So this is the findings. So this is the bacteria. So as you can see over here, this is the expected and beneficial flora. And over here is the imbalanced flora. So just to give you an idea on these numbers range from 1 to 4. The most beneficial over here are bifido and lacto. That's what's commonly in probiotics. We usually want these numbers to be about 2 or 4. So you can say she's a 3 up here, but she's only a 1 down here. So that's something to consider. Over here, you can see that she has 3 imbalanced flora types, and they add up to a +4. So based on this, if you compare this number to her total number over here, she does have a little bit of dysbiosis going on that could be contributing to her symptoms. But the bigger findings were on the parasitology and microscopic findings. So this is sample 1, 2, and 3. These indicate the separate stool samples taken on 3 separate days. I think it's really important to note, probably the first thing you notice is she had a major concurrent infection. So she had several protozoa, amoeba, and fungal infections that were currently going on in addition to dysbiosis. But I think it's really important to note that as you see, many of these were only caught on the second stool analysis. They weren't seen on the first or the second. And this is why parasitologies ×3 are the gold standard, is because there's intermittent shedding of many of these parasites. So the only way to know some of these are currently infecting the patient is to do it over this period of time. So how do we treat this patient? We use metronidazole, which is a prescription medication. It's mostly known for its antiprotozoal effects, but it's also an antibiotic. We also use Alimed potenized garlic, which is a wide-spectrum antimicrobial. We also did a custom formulated anti-parasitic tincture, so we hit her from all sides. We also gave her probiotic to help correct the dysbiosis. We gave her fish oil and turmeric to try to reduce her symptoms that were caused by inflammation. And we gave her activated charcoal that she would have just in case she had a die-off reaction. We also asked her to do a sugar-restrictive diet to limit the prebiotic intake, essentially starve out the bacteria a little bit, make it a little easier to kill the infection. So the results of the treatment. Patient had a pretty severe die-off reaction, which was caused by the toxin released by killing all the infections that she was having. She experienced fever, anorexia, and severe malaise. She was bedridden for almost a week, and she did take activated charcoal that significantly helped. After that phase passed and a few weeks later, the patient had significant relief in her symptoms. Her abdominal pain had resolved. She had a significant increase of energy. Her stool quality had changed to 1 soft, well-formed bowel movement a day, unless she was traveling, which was common for her. She had absolutely no more joint pain. And before she even saw us, she wasn't even aware that she had a heaviness sensation in her chest, that she described as like an elephant sitting on her. But as it resolved, she realized it was there, as well as the palpitations have also resolved. The pruritus on the scalp reduced from a constant 9 out of 10 in severity to an intermittent 3 out of 10 in severity. She had less hair shedding, and she had the ability to grow longer nails without them breaking. So conclusion. So this case is important because this patient had a large symptomology. It covered multiple organ systems, and it didn't clearly fit the classic GI infection symptoms. But the patient traveled a lot, and so just the fact that she had traveled to Africa and had exposure history and recurrent infections indicated that parasitology testing to rule out infection was on the top of our list. While the patient's pathogens that were found are not considered particularly serious, especially when found alone, the number of pathogens she concurrently had, plus the dysbiosis and the severity of the patient's symptoms indicated that treatment was necessary. The testing determined that there were several concurrent infections, which would not have been detected if we had used common medical diagnosis practices, which are either treating without testing, so not knowing what the infection is of, or just doing a single stool analysis where this patient would have been underdiagnosed of 4 infections. So I think that this case speaks that preservative fixative tests can be a very effective way to test and screen your patients for parasitic dysbiosis and pathogenic infections to treat them properly in an outpatient setting. Questions?
Is there any follow-up testing done in the comprehensive stool analysis?
No, this patient lived out of country,
Okay.
so she didn't have a follow-up test done, but her symptoms continue to improve.
Thank you.
So in the previous presentation, I noticed that Dr. Tempe Wright was one of the doctors and authors on it. And so could I ask both her, but anyone else who either was a resident, actually any of the doctors who are here who are not currently on faculty at SCNM, please stand up, because I don't know how many people know this, but we have about 200 doctors in the Valley who participate in our students' education, both as elective side, some of them do adjunct rotations here at the school. So could you guys stand up if there's anyone other than, if not, it's just going to be Dr. Wright. So, our next presenter is going to be doing a case of acute valley fever, which, how many people here have had valley fever and know it? Right. How many people here have had pneumonia with valley fever? Dr. Chang, that means you and me. And Sally's there too. Valley fever is a big deal here in Arizona, in New Mexico, and in California. And our presenter, Dr. Kathryn Purvis, is going to talk about treating valley fever, it looks like, for complications. And she's also completing her residency. Any guesses what she's going to do when she finishes her residency? Her due date is the day after her residency.
We're really good places. As Dr. Mitchell mentioned, I'm going to be talking about a case of acute valley fever with complications of Erythema multiforme that was effectively treated with homeopathy. So Coccidioidomycosis, or valley fever, is caused by the inhalation of airborne spores of various Coccidioides species in endemic areas, which include areas of the southwestern United States, Mexico, Central America, and South America. In the United States, valley fever is actually a reportable disease here in Arizona, as well as California, New Mexico, Nevada, and Utah. The CDC reports that there's been an increase in incidence of Coccidioidomycosis in the reportable areas from 1998 to 2011. In 1998, the incidence was 5.3 per 100,000, and in 2011, it increased to 42.6 per 100,000. So not only has the incidence increased, but it is it's a really common infection in this area, and it also can be severe, with 75% of symptomatic patients missing school or work, and about 40% of symptomatic patients being hospitalized. In fact, among Arizona patients with community-acquired pneumonia, 15 to 29% have primary pulmonary coccidioidomycosis. So valley fever typically presents with a self-limiting respiratory tract infection. On X-ray, findings are similar to pneumonia. However, many other organs can be affected, and cutaneous manifestations do occur. During the acute phase of valley fever, flu-like symptoms occur, as well as desert rheumatism, which includes fever, arthralgias, and skin manifestations. The most common skin manifestation is erythema nodosum, there. And the symptoms of erythema nodosum will appear 1 to 3 weeks after the first pulmonary symptoms. Erythema multiforme does occur. It's not quite as common with valley fever, and if it does occur, then it happens within the first 48 hours of pulmonary symptoms. So conventional treatments for coccidioidomycosis are really debated. Antifungals are sometimes used. Fluconazole is the most common antifungal, but there really aren't guidelines out there to guide physicians on when to treat valley fever and when not to. So our case, we had an 11-year-old male present to the clinic with an oral temperature of 103 for 3 days. The patient was extremely lethargic with severely itching hives that were coalescing into a purple eruption that would turn into vesicles on scratching. He also exhibited a dry cough with wheezes, auscultated in the right and lower lobes, and splenomegaly on abdominal exam. Given the positive sounds as well as fever and rash, we did X-ray to rule out pneumonia, as well as labs. So as you can see here, we had positive Cocci titers, both IgG and IgM. And his chest X-ray documented infiltrates in the right, middle, and lower lobes with mediastinal adenopathy. And so the imaging, along with his positive titers, is consistent with acute valley fever. So we decided on homeopathy to treat this case, not only because he walked into a homeopathy shift, but because it also has a long history of treating acute infectious diseases. Homeopathy is a term coined by Hahnemann. It is from the Greek, meaning similar and suffering. And basically, it's just treating diseases with medicines that are chosen in accordance with the law of similars, or like cures like. So we've all cut a really potent onion and had watery discharge from the eyes, maybe some acrid discharge from the nose, burning of the nose, excessive sneezing, and then gone outside and felt better. So if you have a patient with a cold that comes into your office with runny discharge from the eyes, acrid discharge from the nose, excessive sneezing, burning of the nose that feels better outside, based on the law of similars, you're going to get valley fever or onion. So homeopathy has a long history of successfully treating acute infectious disease and pneumonia. For example, prior to the widespread use of antibiotics, cases of pneumonia were treated with other allopathic methods resulted in a mortality rate of 24.4%. By comparison, during that same time period, which was the literature reviews about 1852, early 1900s, there was a mortality rate of 3.4% in cases of pneumonia when treated with homeopathy. Today, with current conventional treatments, the mortality rate of community-acquired pneumonia ranges between 5.1% to 13.7%, depending on the source that you look at. So back to the homeopathy piece, we chose 2 rubrics to use in our repertorization. The repertory is just simply a tool to get us here to our top remedies. So we chose his skin symptom of the eruptions with vesicles after scratching, as well as kind of the bluish, purplish color that you had in the eruptions. So that took us to these top remedies, laxus, hipersol, and center. And then we went to the Materia Medica in order to read about those remedies. Materia Medica is really just a list of symptoms that those remedies produce. So for example, our top remedy there, laxus, has these symptoms in the Materia Medica. So for example, hives on the shoulders, itching hives on the legs, purplish color of the affected parts, dry and wheezing paroxysm of cough. Sounds a lot like our patient. So based on the law of similars, we gave him laxus. So we started with laxus 1N, 3 pellets, and we gave it to him every 2 hours. So within 24 hours of starting the remedy, his fever began reducing and the itching and hives began to lessen. 2 days later, though, his hives started to come back a little bit. We were watching him really closely because he was having this high fever and because of his lung symptoms. So we followed up with him really regularly. And within 2 days, his hives started to worsen. So we made a little bit of a change in the remedy. He had the same symptoms, so instead of changing the actual remedy, we just changed the potency. So we increased the potency to laxus 10N. At 1 week, he hadn't had a fever since the weekend, which is about 3 days later. I guess 4 days later, we followed up with him. His lungs were clear of auscultation. The rash was significantly improved with less itching, and he had no hives, and the skin was starting to restore to normal color. And he was continuing to improve at that point, so we stayed with the same remedy and potency. At 3 weeks, his lungs were clear of auscultation still, and the rash was pretty much completely resolved at that point. We ran follow-up labs. As you can see here, his white blood cells started normalizing, as well as his sed rate and C-reactive. And Follow-up imaging showed resolving infiltrates in the right middle lobe and just mild adenopathy. You can see here the improvement in his rash. So this was when he came into the clinic the first day. This is just 1 week later, almost completely resolved, and this is pretty much normal at 2 weeks. And same thing with his palm. This is pretty classic looking erythema multiforme. Again, pretty much gone, and in 2 weeks, completely gone. So over the course of 3 weeks, the patient showed improvement in all of his valley fever symptoms, including his erythema multiforme. Valley fever typically resolves in a few months. There was a study done here in the Valley at Mayo Clinic that wanted to look at the typical course of valley fever, both with antifungal treatment and with no treatment. And the study shows that the median time from symptom onset to 50% reduction and complete resolution for patients with mild to moderate symptomatic valley fever in those receiving antifungal treatments was 9.9 weeks and 18.7 weeks, respectively. In those with no treatment, time from symptom onset to 50% resolution was the same, it was 9.9 weeks, and time from onset to complete resolution was 17.8 weeks, so it was actually shorter in the non-treatment group. So in contrast, our case demonstrates that homeopathic treatments have the ability to resolve the disease course within just a few weeks, which is significantly faster than either non-treatment or antifungal therapies. Additionally, erythema multiforme typically presents lesions over 1 to 2 weeks that subside within 2 to 3 weeks, and as you can see in our patient, it started resolving within 3 days of symptom onset and was completely gone by 2 weeks. Again, with erythema multiforme, recurrence is really common and occurs in up to 1/3 of cases. We last saw our patient 4 months post complete resolution of the symptoms, and he had no reoccurrence. So this case shows that the time of onset of symptoms to resolution can be decreased with homeopathic treatment. Any questions?
I think you said Mayo Clinic study, did that include pediatric patients as well?
They didn't. There were some college-age kids, but that was.
When I had valley fever, I remember a friend had connections and got me in the next day at the Arizona Valley Fever Center of Excellence. It's a project at U of A and St. Joe's. And just as you said, there's really, there wasn't really a candidate for antifungal treatment. And so came back here, saw Dr. Deng for acupuncture, homeopathy with Dr. Messer, and then IVs. And really within like 3 days, I was dramatically better. So I'm a personal testimony to what you're describing. I noticed that there are staff people. Our staff people are not only work all the time here, but here they are. They're not clinicians, they're not medical people, but they're here participating with us. And so can I ask anybody who's a staff member at SCNM to please stand up? Dr. Kathryn Raymond, who is going to be moving back to Connecticut, where she will be opening a private practice, or joining a practice, opening a private practice, and she's going to work working with children in similar patient populations, which she's going to describe today.
Is this working? Yes, maybe? Kind of? Okay. All right, I'm going to try and include everyone over here too, but we'll see. It might get hard. Everyone's been standing on this side. Okay, so thank you. I'm presenting, so my paper that I wrote is not yet submitted for publication. We're making a lot of edits to it, so it's almost done. It's actually 3 cases, so it's a case series of children all treated, they all had ADHD and they were all treated with homeopathic lycopodium. But for the purposes of tonight, I'm just going to present one case because we have a limited amount of time, and I talk a lot. Okay, so attention deficit hyperactivity disorder, what is it? It is a neurobehavioral disorder, and there are 3 subtypes. There's the predominantly hyperactive impulsive type, the predominantly inattentive type, which used to just be called ADD, but it's now a subtype of ADHD, and the combined hyperactive impulsive and inattentive type. It's basically characterized by difficulty remaining focused, controlling behavior, and hyperactivity, and it affects a lot of U.S. children. Approximately 6.4 million children in the U.S. are diagnosed with ADHD. Conventionally, they use stimulant and non-stimulant medications, but most frequently they use stimulant medications, and Ritalin is probably the one that you guys would recognize the most because it's the most commonly used medication. So, what do we know about homeopathic treatment in ADHD? So here's some studies that have been published. Heiner Fry is a researcher in Switzerland, and in 2001 he published this observational study on the treatment of homeopathy versus the treatment with Ritalin in kids with ADHD. And in the study they used the Conners Global Index, or CGI, as their measurement tool for how much the symptoms improved. This is a really, I just put up a little study here, it's a really valid tool. It's been shown in the literature to be really accurate in scaling the severity of the symptoms. So in 2001, in their observational study, they had a goal, they considered a treatment effective if it reduced the severity of the symptoms by 50%. So what you can see here is that homeopathy was pretty effective. So first they started all the kids in the study off with individualized homeopathic treatment. And they were able to reduce their CGI scores by 55%. You can see up there. And 75% of all the kids in the study responded and had a successful treatment. So of those kids that did not respond, then they switched them to Ritalin. And 48% of those kids then responded and had an improvement. 65% of those kids then responded, and they reduced the severity of their symptoms by 48%. So to be fair, we will say that the methylphenidate were all the people that treated with Ritalin were all the kids that didn't respond to homeopathy. So maybe they were a little bit harder to treat to begin with. So maybe we could have given a better shake to Ritalin. Maybe it would have been more effective. But still, it shows that homeopathy was very effective. Okay, in 2005, Fry did another study. This was a randomized control trial, and it was a crossover trial. So they gave the patients both homeopathy and placebo treatments. And the CGI scores showed more improvement under homeopathic treatment than under placebo. So we can conclude that homeopathic treatment is superior to placebo treatment. Okay, so why lycopodium? If you combine all of the subjects in both of these studies, over a third of them responded to one of 3 remedies. That's pretty significant because there are hundreds of possible homeopathic remedies that they could have been given. So if over a third of them responded to one of 3, or to these 3, then that means that we should probably take a closer look at some of these remedies in consideration for treatment of ADHD. And lycopodium was the second most commonly prescribed. Okay, so let's look. Again, Dr. Purvis introduced us to homeopathy as like cures like. So the symptoms that a substance causes in a healthy person could be removed in a sick person by that substance. So if you look here on this slide, these symptoms in the first column here, for you guys over here, are symptoms that look a lot like ADHD. We call them pathogenic symptoms. So excessive excitement and apprehension, inability to hold on to a thought, restlessness, impatience, distracted action, low confidence, choosing wrong words, and mistaking when reading and writing. A lot of kids with ADHD have that. And then the second column, you guys aren't looking back there, the second column here is just some symptoms that are going to be specific in the case that we're about to look at. Okay, so a 10-year-old male presented with ADHD and oppositional defiant disorder. He had extreme difficulty staying on task. His teacher had to redirect him more than once a minute during the day. That can be really frustrating. He was constantly receiving punishments, really restless, impulsive, and had angry outbursts at home where he'd slam doors and refuse to follow instructions. On the first visit, we did a parent CGI score, and he scored an 11 out of 30, which is pretty high. Not super high, but it's up there. And so it's interesting to note that in this case, all of these symptoms started after he moved from out of state 2 years ago. So they've been going on for about 2 years. So that's not really something that conventionally doctors would take into account, right? That there was this emotional disturbance that kind of happened at the onset of all these symptoms. But in homeopathy, we pay attention to that. So he was complaining daily of missing his old school. He was really bossy, refused to play with kids that were younger than him. He was sensitive to sound, couldn't go to events, had a lot of trouble falling asleep at night, complained that his stomach hurt every day before school, and had pretty severe allergies. Okay, we put all of those symptoms into our computer, where we have this fancy computer program that rates those symptoms, and lycopodium comes up first. It's interesting to note that only 2 remedies cover all of the symptoms that he has. So that's pretty interesting. All right, so we chose lycopodium. We had him take a 30C for potency of lycopodium every day, orally, and he came back 4 weeks later for follow-up. His mom reported a massive improvement in his ability to focus. He wasn't getting in trouble at school at all anymore. He no longer mentioned his old school. He was less impulsive. Before, he'd been sneaking food at home, and he wasn't doing that anymore. He could go to bed without getting up. Previously, he would get out of bed 4 to 5 times per night when they tried to put him to sleep. He was arguing less. He could go to his brother's sporting events, and his mom said he was no longer haughty, and the kids his own age were acceptable to play with him. Okay, so he came back for a second follow-up another month later, so 8 weeks from the start of treatment. And his ADHD symptoms remained improved, not a problem. His mom reported that he was starting to argue more at home. So he was a little bit worse than he was at that first follow-up visit. At the first follow-up visit, we hadn't had her fill out a CGI score. We had her fill one out now. Even after he's a little bit worse, he's still 85% improved from where he was before. So that is pretty significant. So let's compare this to, and he continues to improve on different potencies of lycopodium. So compare this to those studies we looked at before. He had an 82% reduction. In the studies, there was a 55% reduction and a 48% with Ritalin. So he had a really great response, and homeopathy was very effective in this case. So in summary, lycopodium is a commonly utilized homeopathic medicine in ADHD. It's safe and effective. It worked as well as or better than conventional treatment, and it works really fast. He had symptoms for 2 years that were pretty severe, and he's 82% better in 8 weeks. Anyone have questions?
That was wonderful. Our last presenter, Dr. Miriam Wheeler. Dr. Wheeler is going to complete her residency, and then she's going to do a 2nd-year residency as a homeopathy resident at SCNM. And, I want to acknowledge a couple of things. First of all, the homeopathy residency is the only homeopathy residency in the United States at a naturopathic or any other medical school. And one of our trustees, Jay Borneman, is the CEO of Standard Homeopathic, and Jay Borneman, Margaret Murphy-Moore, and the people at Standard have donated almost $1 million over the last 8 years to support the homeopathy residents here at SCNM. So thank you very much to them, and welcome to Dr. Miriam Wheeler.
So, you guys can hear me? Okay. Thank you all for being here this late on a Friday evening. I kind of expected half of you to be gone by the point that I got up here to talk, but thank you for sticking around. So I wanted to start by acknowledging, so my talk is on treating diabetes and actually reversing type 2 diabetes with a plant-based diet. And I just want to start by acknowledging that the topic of diets can be rather emotionally charged for some of us and also sometimes a controversial topic. I'm not intending to criticize any one particular diet, but rather I am hoping that this kind of encourages a conversation amongst ourselves and just kind of help us kind of discuss the existing evidence in the literature regarding diets and the role that they play in health. And as new research emerges, we might decide that a different dietary approach is actually more helpful. But right now, based on the literature and the current existing research, it looks like a plant-based diet seems to be quite promising.
And so with that said, let's talk about the role that diet plays in one of the leading causes of death in America. So type 2 diabetes is a disease of lifestyle, and it occurs when people have excess blood sugar. Over time, this leads to insulin resistance, and eventually this hyperglycemic state can cause damage throughout the whole body. There's a lot of complications associated with type 2 diabetes. They're listed here, and if anyone's looking over here, I don't think I'm going to reach over there, but there's a whole bunch of complications. Ultimately, it can even result in death, and usually for diabetics, the death is a result of heart disease. So that's important to keep in mind when we're coming up with treatments for diabetic patients. Conventional treatment for type 2 diabetes primarily consists of medications, and the American Diabetes Association actually no longer promotes weight loss as a primary treatment, and this is primarily because conventional dietary approaches just aren't very useful. Patients can't stick with them long term. However, this approach of relying on medications isn't good enough for our patients. The number of Americans that are diagnosed with type 2 diabetes is increasing at a staggering rate. And it's estimated that by the year of 2050, that 1 in 3 Americans will actually be diabetic. So this is a disease of lifestyle, and that means that it's always preventable. It is often treatable, and sometimes it's even reversible through diet, as you will see with our patient. So Lori, whose name has been changed to protect her identity, is a 61-year-old female, and she came into Dr. Oskin's shift this last November. She had just been diagnosed with type 2 diabetes on a different rotation through routine screening blood work. However, this wasn't a big shock to her. For the last decade, she knew that she was pre-diabetic or insulin resistant. She hadn't done anything medication-wise to treat or reverse that trend that she was on. She had tried various diets over the years. She had struggled with her weight her entire adult life. But no diet had ever given her long-term effects. And even though she hadn't been successful with diets in the past, she was really adamant that she didn't want to start medications this time around. And this was partly due to cost. She and her husband are on a fixed income, but it was also partly because she was concerned about the risk of potential side effects associated with medications. And so she and Dr. Oskin agreed that they would start with a pretty radical dietary change first, and if that wasn't enough, that they would start medications in the future. And so our treatment plan was pretty simple. We gave her some homework, we had her read a couple books, both of them by Dr. Joel Fuhrman. We had her read The End of Diabetes and his accompanying cookbook, The Eat to Live cookbook. And then we told her to implement a nutrient-dense, plant-rich diet. We asked her to increase her exercise just a little bit to make sure that she was getting out and moving every day. And we put her on a multivitamin to make sure that she was getting sufficient levels of B12 since she wasn't going to be consuming a lot of animal products on this diet. So what is this plant-based diet that we started her on? So a nutrient-dense, plant-rich diet is the plant-based diet version that we implemented with Lori, and it's outlined in Dr. Fuhrman's books. And Dr. Fuhrman talks about this concept of nutrient density, and he says that health is determined by the nutrient per calorie density of your diet. And so the emphasis on a nutrient-dense, plant-rich diet is micronutrients, so the vitamins, minerals, antioxidants, phytochemicals. So rather than counting calories or counting carbs, you're focusing on foods that give you lots of vitamins and minerals. And so it just so happens that the foods that are really rich in those types of nutrients are plant-based. So green leafies, colorful fruits and veggies, beans, nuts, seeds, those types of things. So that's what this diet really emphasizes. And this dietary model is different